Good morning, everyone. It's great to see everybody. So first I'll talk about this metachromatic leukodystrophy slideshow. Is from a while back. Things have been moving quickly in New York State. We are poised to start screening for MLD. So this slideshow, I'll be inserting some more updates of where we are as I go. So MLD, unlike Krabbe disease, I think Krabbe disease taught lots of lessons for how to screen. And when we first started screening for Krabbe disease, we looked at one enzyme alone. There was no biomarker tests. We had really little idea of what it meant to have low activity with two variants in a gene that could be considered pathogenic, quote unquote. And we looked at a lot of variants that were associated with late onset. We were picking those up, and Amy earlier talked largely about that group of variants we've seen quite often. But now, metachromatic leukodystrophy, from all these lessons, some of the things were, well, we don't want to have a screen where we have less certainty in what it means. And so things moved actually really fast. I think combination of the fact that we had learned a lot from Krabbe disease and other screening for lysosomal storage diseases, as well as there being a group of people that were behind this because of the therapy that was going to be available in both Europe and the US. So this is just kind of a record of how quickly things moved. Actually, the first real paper was somewhere in 2019 on screening for MLD, and here we are in 2025. And it's already being screened for in the EU. There's been a couple of newborn screening papers. The most recent one, reports on a new sulfatide that can actually improve the screening. There's ARSA enzyme assay. So we're going to talk about that, and I'm going to go over things and give an update on New York as I go. So the original screening test, 27,000 babies in Washington State at Michael Gelb's lab in conjunction with the Department Health Newborn Screening. It was a liquid chromatography mass spec method, which is different from what we've been used to in the labs. And I think a lot of laboratories have adopted this technology used for ALD screening, but it's generally just for ALD screening, and smaller state labs. Larger state labs are still using a kind of a faster flow injection method like New York State. The idea was if you saw elevated C16 sulfatide, which is what was observed in 15 newborn dry blood spots with MLD patients, that these patients would go for ARSA enzyme activity. And if that's also low, then sequencing would be performed, and this would lead to a diagnosis for MLD with appropriate follow-up. The method has since been refined since it was being used in Europe, and it was determined that C16-0OH or C16-1-OH sulfatide, in addition to the C16-0 sulfatide, if both those markers are elevated, then you could reduce the first tier screen positive rate, and it would be about a factor of 5. So it went from a 0.71%. Sorry. Yeah, it went from, did I skip a slide somehow by accident? Ooh, where'd it go? Yeah, sorry. Maybe I should wear my glasses up here. So we have 0.71% versus a 0.035%. I'm still on the wrong slide. Yeah, 0.047% versus 0.7%. So either way, though, that's a fairly high screen positive rate requiring ARSA as a second tier assay. So New York State's plan is actually looking at, there's a paper published by Michael's lab as well, where they look multiplexing enzymes such as Krabbe disease, Pompe disease, MPS 1, along with adrenal leukodystrophy. And you can also put metachromatic leukodystrophy in this assay. So my lab's been working towards adding this as a one screen for all of our disorders in the lysosomal storage lab. To do the full 18 screen assay, you needed 4 DBS, but what we need is just 2. One right now is an extract for markers, and one that's is used for the enzymes. But is a move now within Phanos to be able to do these screens with just a single punch, where you can get the markers and enzymes out of a single punch. My lab will explore that later, but we were on a path with the 2-punch assay, and we're sticking with it because we need to start. We were theoretically supposed to have started July 1st. I think it's July 14th now, so I'm 14 days behind. Anyway, we're very close. And where we are in my lab, just to give an update, is the validation is complete from the standpoint of we've proven we can run our multi-enzyme MLD, ALD assay. We're just verifying all the instruments match. And then we have a submittal to what's known as our clinical lab evaluation program, where they'll okay whether we can proceed with screening. We expect just a conditional approval, and that would take something like a week or 2 to get done. As a side note, and there'll be more to talk on this in a minute from Andrea DeBarber, CTX, or cerebral tendinosis xanthomatosis, is also possible to screen with this exact same assay. And the laboratory is poised to do that. We've validated it along with MLD, but we're having somewhat of a pause in initiating that because of the therapy being FDA approved only for adults. We want to just get everybody on board in our physician side with how we'll handle getting CTX positive patients in a newborn period. So we want to make sure everybody's comfortable with what needs to be done. But here's the basic MLD screening assay. You basically extract with methanol with the sulfatide standards for 4 hours at elevated temperature. Centrifuge to pull down any protein, drug, or particulates and things of that sort. Transfer 100 mics to another plate, and then perform the LCMS. So it's fairly straightforward from the procedure point of view. If you're just going to do MLD, if you're going to do it with the other enzymes, you have to do a combination or combine the extracts. And this is originally published by Hong in 2018. Just as for those labs in this state programs, there is no FDA approved approach. But people that are doing ALD screening and can do lab developed tests could easily add this in to do MLD. By easily, it's just really as simple as maybe extracting slightly different and adding the deuterium labeled MLD sulfatide materials, and then performing the screening. Of course, you still have to contend with an ARS assay. New York's which is, by the way, we're contracting with the Mayo to do at this point in time. So that would be probably the most recommended approach for labs that are looking to start MLD screening and already are doing ALD screening with an LCMS method. So New York was provided with, we have the Eunice Shriver NIH grant that has been for Screen Plus. So we've been screening for MLD for several years now, but on a much smaller population. So we've gotten our feet wet there. That project's still ongoing, but MLD will come off of that as we add it onto our full panel screening. This is just a very small diagram that says basically what I've said. We're going to screen for 2 enzymes that they're both elevated. And we do ARSA testing. If that's low, then it's going to go on for genotyping. So that's the basic workflow. So this number right now is about 30,000 MLD screens. We have somewhere in 130 babies with elevated, just the single sulfatide. We weren't running for the vast period most of the time with the second sulfatide, so we're not really sure what that's going to be like until we start going live screening for the full population. But we're certain it's going to be lower because we did go back and look at a lot of our positives, and the second sulfatide was normal on those. This is incorporating the C16H1 OH sulfatide. And what I think is really interesting is, and point out to newborn screening labs, is this uses a multiple median cutoff approach, which was largely because it's very difficult for laboratories to get positive samples. And the laboratories that have been involved with this screening, including the Washington lab, have tested as many as they could get their hands on, as well as those MLD cases that have been picked up through screening, and they determined what a multiple median cutoff could be. This paper is a way of or not having to necessarily get a bunch of positives yourself to set a cutoff. I think it's overkill. I've been having a hard time convincing people of this, but Michael Gelb and I can try to convince everybody we can. Is just stick with this multiple median approach, and you can be screening with essentially just setting up your lab, determining a median, and then use the cutoffs that are recommended in this as a multiple median cutoff. My lab will do this in a more in a concentration manner. We won't actually use a multiple, a median, but we'll set a concentration that's based on a multiple, a median, and then hold that those medians stable. I can explain that if anybody wants on a side. It's just quick validation. This linearity series, it looks like there's a couple of points that are low. This seems to be actually the controls because it repeats itself over and over and over. And I've seen it in other labs that look identical to this. So I'm like, it's got to be the controls and not actually the method. So it's very linear. Accuracy is good. These are blood spots, blood that's been spiked with the sulfatide materials. And so we can check accuracy, linearity, precision with this group of standards that are available. There are Revity versions as well as versions from the Infanos laboratory. Second tier is an ARSA enzyme assay. I'm not going to go into the details of that. We're using Dieter's lab, Dr. Dieter Matern's Mayo Clinic lab for that. I believe that the South Carolina lab, and I'm having trouble remembering the name, also is set up to do ARSA. So there are multiple labs that are capable. Greenwood, thank you very much, Michael. Greenwood has already validated a method and is going to be accepting samples as well. Then third tier is ARSA sequencing. There's been a lot of work done in what variants can be observed, and actually every individual variant and how it affects the enzyme activity has been studied by Michael again. So this is very interesting work. Points to a large predictability of who may develop the more severe two forms of MLD, and can act as a guide when people have a screen positive. I'm not sure if that data is fully published yet, Mike, the second paper. But yeah, there'll be more talk about it. So yeah, it's very interesting and helpful, but in kind of in line with also looking at clinical results and some of the clinical evaluations, be able to determine who would go on for therapy. In New York, this is interesting. If you actually sequence the group of individuals with elevated sulfatides, you get very little useful information. And I think it's because the main reason is sulfatide levels of normal individuals are there's a lot of overlap between those and the sulfatide levels of MLD patients, hence the need for the ARSA assay. But in most gene screening with enzyme testing, what we find is plenty of variants that point to an explanation for the low enzyme activity. But in this case, the elevated marker concentrations don't necessarily mean anything's going on in the ARSA gene, although we did see a fair number of them with so-called benign variants. And these could probably be benign. Any benign variant could knock down enzyme activity, but still cause some elevation in sulfatide that wouldn't lead to disease. So there's some possible explanation. But in the end, most people are going to have to contend with this because they're going to have an ARSA assay. So this was our makeshift way of dealing with things and trying to learn things as we went. And we learned very little. So we are just really close to getting this started. I'd say 3 to 4 weeks. And when I get back, I'll be finishing up the write-up and submitting the CLEP validation, and that should be, then we'll look for approval and we'll be starting as soon as we can. So thanks very much.